but can you tell us a little bit about your case?
Yes, we have here, let me introduce the team here. We have Dr. Goodman and Dr. Stegman, two of our second-year interventional colleagues that are graduating soon. Unfortunately, I'm going to miss them. So Dr. Goodman is going to present the case now.
All right, so this is our second live case of the day. Next slide. So this is a 59-year-old gentleman with history of hypertension, hyperlipidemia. He's on insulin for his diabetes. He has coronary disease, status post bypass surgery in 2003 with an EF of 45%. And he has significant peripheral arterial disease. He came to us with a non-healing wound of his right toes and his heel. As you can see the wound on the right there, both the wound on the toes and on the heel. He has no evidence of osteomyelitis on his x-rays. Next slide. In 2009, he presented with CLI. He had a right iliofemoral endarterectomy with a patch angioplasty. He had a profundoplasty with patch angioplasty of the proximal SFA and endarterectomy with a patch angioplasty at that time, and they did PTA to the distal SFA with a 5mm balloon. Next slide. In 2010, he presented for left side CLI, and at that time had distal SFA popliteal recanalization and atherectomy with a pathway, and balloon angioplasty with a 5mm balloon, and had AT, PTCA, and aspiration thrombectomy at that time. Next slide. 2013 came back for the left side, CLI again, had left iliofemoral and profunda endarterectomy, patch angioplasty, left CIA stenting with a 10/60 self-expanding, and a left CFA to AT bypass with PTFE grafting and basilic vein. Next slide. And on the left, just recently, about 2 weeks ago, he had SFA popliteal recanalization and stenting using self-expanding stents and Supera stents, and PTA of the profunda with a DCB. His left foot is nearly completely healed, and so he comes back for a stage intervention of his right leg to address the CLI on the right side. Next slide. Non-invasive studies, we have ABIs with toe brachial index. As you can see, ABI on the right is severely reduced. His TBI is 40. Next slide. He'd have a CTA with runoff. As you can see, no significant inflow disease. The stent at the left, CIA, is patent. The right SFA is occluded. The bottom panel there is 3D reconstruction, so you can see the ostium of the SFA there. Heavily calcified disease, popliteal, severe diffuse disease of the AT and the TP trunk with 3-vessel runoff to the foot. Next slide. So he had prior angiography. So this is selective angiography of the right common femoral artery. As you can see here, we demonstrate the occluded SFA, both in the REO and the LEO projection. Next slide. Video on the left here is reconstitution. And as you can appreciate, there's actually 2 areas that are CTO. Next slide will play the 2 following videos. The middle and the third panel there. So again, you can see the runoff with reconstitution into the popliteal, which has significant disease distally just prior to the origin of the AT. And as you can appreciate on the far right, occluded AT-PT with patent peroneal to the ankle. Next slide, we'll see the foot. Next slide, please. So this is the runoff to the foot, and he has that peroneal to the foot with AT and PT reconstitution from collaterals. Next slide. So in summary, he has a right SFA CTO with reconstitution in the mid SFA and a second area of occlusion in the distal FA into the popliteal. There's also a severe lesion in the distal popliteal, and the TP trunk is diffusely diseased. The AT and PT are occluded proximally, reconstitute in the foot from peroneal collaterals. Next slide. So our plan was to attempt antegrade recanalization of the SFA, consider a retrograde popliteal approach if necessary, angioplasty. We wanted to reconstruct the popliteal into the TP trunk and peroneal, and we wanted to discuss DCB versus Supera versus DES.
Great job, Andy. And, we are having a little bit of challenges. Obviously, that's the beauty of live cases. So if you can show this monitor, please, let me show you. We've been trying to get the sheet up there, and there are not a lot of pictures. But basically, we are having a little bit of trouble passing the sheet. As you know, his groins have been operated on multiple times. So he has extensive groin surgery in the past. And also, he has had a prior stent in the iliac. So we are able to get the sheet across the bifurcation of the iliacs, but not down to the common femoral. Despite putting a stiff angle glide wire, putting a balloon in the profunda, and trying to rail it over the inflated balloon. So various techniques. So I think at this point, one of the techniques we have used in the past and something to show is to get popliteal stick for a number of reasons. One is that it's going to help us to wire this retrograde, given the challenges that Andy described. And the second is that, I think once we are able to, God willing, cross the lesion and externalize the wire, I think we'll have a better rail to be able to get that sheet down, Craig. Other than that, I leave it up to you, and we're going to show, if you don't mind, just for the sake of time, I'm going to show the popliteal stick in the supine position at this point, and then from there we can go on, if that's okay.
Sure.
Mehdi, I do have two remarks. Why are you intending to go through the popliteal? The main or the most important artery is the anterior-tibial artery, which is almost patent down to the foot. There is an area at the origin which might be diseased, but everything else is patent. So why don't you use the anterior-tibial, which you will need to open for improving wound healing, number one. And number two is you have also disease of the deep femoral artery. Are you intending to treat this as well?
Yes, the deep femoral, I think, needs to be angioplasty. I think that's a good point. The reason, Thomas, to go for the... but let me just show you this, and I'll give you the reason to go for the popliteal here. So to get supine popliteal approach, we externally rotate the leg, as you can see here. We then put in a frog position. As you can see here, the leg is in about a 40-degree angle, like this. The II, you want it to be in the ipsilateral view, so this is about 26 degrees right now. And you want the needle, the vessel, and the II to be in the same kind of a view. I have a Cook needle here, and basically we have calcium, so I'm pushing on the calcium. And you can feel it actually. So we got a little bit of return. So let us look at it here for a second. Whether it is arterial or venous, sometimes it could be venous. And I'm going to explain why I went for this versus the AT, which I think is a very good point that Thomas raised. But let us just show this for a second. I think this is the vein, most likely. Yeah, this is the vein, which is fine. Yeah, this is the vein. So, hold the wire for me. So again, you want to be as parallel as you can. Now, if you hit the vein again, you can go to a different location. Yeah, that's the vein again. Okay, that's fine. So I'm going to pull back here. Watch my needle.
Just a question, maybe this is a 18 gauge needle,
Yes.
or 21 gauge needle?
This is a 035 needle that I'm using. So 035. I like this area because there's not a lot of calcium actually. So that's why I'm trying to use this area. Yeah, we are passing it. So what we're going to do here is that
Could you show us an angiogram of this area to understand where the calcium is located, whether it's more the anterior or posterior wall?
I'm going to show it to you right now. Here, I'll show you an angiogram. Don't move. You can see it's heavily calcified and severely diseased.
Yeah.
Yeah, so it's heavily calcified, severely diseased, and our sheet is kind of stuck in the iliac area. So we can't bring the sheet down, so that's part of the reason. But we'll get this, just give us a second.
Yeah, don't hurry.
Okay, we now got it, okay? We now got it. So you know the flow and the, I think this should be it, hopefully.
Yeah,
Hopefully
even
it's
with a
not the
long
vein again.
occlusion in the popliteal, you should see pulsatile flow with a big needle. So with the bigger needle,
That's the vein again.
you should see that.
So maybe to
I'll
find
show you.
out whether you are in a vein with a needle is maybe helpful to also give other angulations. So, for example, if you go now,
Yes, I'm
Try
going to
to
do that.
peek, you
I'm
might
going to do
see.
that because, well,
yeah, whether you're with a needle through the artery into the vein or not.
so that's what Andre was teaching earlier, and you can see here that we may be through,
Yeah.
which I think is the case, to be honest with you. So we can show this. This is actually a good teaching point. You can even see it by calcium, to be honest with you, but let us show it here. You see how the needle is past it. So what we're going to do is that,
This must.
Yeah, that's the problem always with
So
calcium, that the needle jumps.
Yeah.
And, difficult.
okay, I
to
got it
move,
now, I got it. You see the flow now? Can you show the flow?
Yeah, flows.
So that's
nicely.
you definitely see the flow now. Now is the time that you don't want to mess this up because
And what wire are you following this with, Mehdi?
this is the stiff angle glide wire.
Okay.
So I'm just gently going to pull it back a little bit. I don't want to cause a dissection. Yeah, so I don't like, can I get it toward here? The other option is a V18. Can I get a V18 quickly?
So maybe also for
So
getting
this is
the wire out of the needle into the artery, maybe this other angulation might be helpful. What do you think to?
maybe better, yes, yes. Can you inject some dye? Okay.
Yeah.
Of course, Andre is always right, so that's why we listen to him. That's why, and that's why we have him here to help us. But you saw that how we did that. I think that was hopefully a good teaching point. So now we are in the artery. So the key is, again, the points that Andre mentioned earlier this morning. Watch that wire doesn't come out, Andy, please. That wire. So now what we're going to do is that we're going to follow this with a Navicross. So it's a 035 support system from Trumo. So I feel like I have good purchase there. So let's put that.
And this is a soft Trumo or a stiff Trumo?
This is a stiff Trumo.
Yeah, to give good support for the Navicross.
Yeah,
right, yeah.
hopefully we have a good support here. So now we're coming down with the Navicross, and I have to still answer Thomas's question as to why we didn't go for the AT, and I will hopefully can show that. Very good. Got it. So now here, you just want to hold pressure. You see how easily this goes actually. So come over here, Andy. So now you can put the leg in a straight position, so there's no need for proning the patient, doing all those things. You can see we can put the leg back in where it was. And now we can go in the AP view. Floro, get the torque for me, please. So hold it there, Andy. So I'm going to pull the wire back a little bit here. And just we're going to go in a retrograde approach. Come up a little bit. Come up a little bit. And I'm going to show you why we did this, because we've been working hard trying to get that sheet down, and we've been having some difficulty. So let us take a picture here. Okay, see? Okay, so we are in this position here. So let us use this as a roadmap. Follow? So now we have a stiff angle glide wire. We are injecting from the top. We are here in the, so I'm going to pull the wire a little bit back. One second. Okay, come up a little. I stop right here. Now we're getting a little bit off track here. So the goal would be here, if we can cross, it would be great. Can you come back a little bit? So come back a little bit. Yeah. So, okay, come up there. So now here you got to be very careful, obviously. Stop. So we don't want to damage the profunda. We don't want to dissect into the profunda. I want to take a couple nice views here. Make sure where we are. Can you get another Navicross and a stiff angle glide wire? So we're going to give it steep angulation here, and we're going to take a couple images here. See? So that doesn't look that bad. What do you guys think?
Yeah, I think you're at least headed in the basic architecture of the vessel. We'll see in just a second. It's a little bit medial,
Right.
but I think you can direct back here. This is not a regular vessel. This is a vessel that's had a lot of surgery. It's had traction applied to it, and there's a lot of talk in the surgical meetings that intervention often takes away surgical options. The truth is also a lot of surgery may take
Can I have
away
another
intervention
Navicross?
options.
Absolutely, I think these
So
are
now-
really one of the most challenging cases when, I mean, even if
Navicross?
endarterectomy has been done on the proximal SFA, there's so much scar around.
Can I get it?
At the end, very
550
often
below?
we end up with some re-entry devices
by
from
100.
retrograde to come back here into the common femoral.
Yeah, there's traction. The anatomy's different. The layout of the vessel is different. It's a little more difficult to traverse. You've done a great job so far. That's a very nice case.
So what's the issue here is that now if you're uncomfortable, in my opinion, what you can do is that you can come through. You can come now from the top. At least you have a landing area. So you can come from the top. So now we can bring this from the top. Take this wire up. So if, let's say you're uncomfortable and you're not sure you're going to compromise the profunda, you want to be kind of more confident about your decision making. So one of the techniques you can use is that now that we have a marker there, so turn the Navicross toward this, yeah, and then come down here. Turn it. So you can use the Navicross to turn it. Okay, let's do another picture here. 1 second. Let's go to the contralateral view. And you come on this side.
Well, you should go
So we don't come on-
into a right oblique view here, because otherwise you will
So
not
it's
see.
interesting.
Yeah.
Here we are far away. Okay, try not to move. Okay, so that's interesting. So that's good actually. But what I'm going to do, I'm going to use the roadmap here, reference this, and okay. So what I want to do, I want to turn this towards this side. Put the roadmap, please.
Yeah.
It didn't go on. Let us put the roadmap. You see the knob is right there at about 4 o'clock,
Yes.
if you agree.
Yeah, but I'm to be honest, I'm not so sure whether this is really the true origin. Because now you are in the left oblique position here, and usually the offtake of the
It comes on the
SF
other side, yes.
is easier to see on the right oblique position. So I would, to be honest,
Yeah, I will go back past the
Yeah.
right in a
I
second.
agree, Tom. I think that's.
Yeah. Not. Hello?
But
So
for the
that's pretty good,
audience,
actually.
the reason he wants to approach this from above is his fear is if he simply pushes the wire, he may get into a dissection plane as he enters
that's
the
right.
common femoral, which may compromise the profunda. So his goal is if he can get the wire to start to cross from above, snare that wire, then there's less risk of injuring the profunda, and it allows him to treat both the SFA and profunda.
Unfortunately, the Navicross does not. Can you bring a GR4?
Yeah, I believe a more angled diagnostic
Yeah,
catheter
with more angle, yeah.
would be better, right Judkins or
I-
even an IMA.
Come on.
And
Yeah, bring a 5-frame GR4 and also IMA. Fluoro from me.
And the problem of Navicross is if you have a hydrophilic coating, it will slip back. So this is not so easy to position here.
Yeah, I see you're going behind it. So we want to show a couple things here. This is so free here, it's weird. You know, you see how free it is?
Yeah.
Come back here, right? So while they're getting me that GR4, I'm just trying a couple things. Yeah, this is, okay, give me the GR4. Also give me an IMA. So let's take this out for a second. Fluoro, IMA, you gave me IMA? Is that IMA or GR4? Okay, give me the IMA. IMA may be better, yeah. Hold the wire. Okay. Come a little bit faster, Brian. So let us try this in two views. So these are some of the, go ahead. So we're going to come with the GR4 here and see if we can point it. Remember, he has had the common femoral endarterectomy and patch in the past and prior bypasses. So some of his anatomy is all changed. Let me come to this one. Give me a little test here. Okay. I know he's not looking at it. I just gotta get it out. Okay. I see part of the problem we have here is that we can't get a sheet down. The sheet is stuck over here. Let me show you so you can see. See, sheet stuck over here. And despite doing some angioplasty and some hard work, we haven't been able to get it down. So I didn't want to spend the whole time doing that. So I think that if we can get this wire down, then we can rail it and get the sheet down. So that's part of the reason we wanted to go for popliteal, because we wanted to have more of a, let me see here in this view. Let me check in the other view. Do a little test here. Let's see. One second. I think that looks good.
I agree. That looks like the stump, or at least what we think is a stump.
Right. So let me.
It's indeed very helpful to have an angle catheter which you really directly get into the tip or the stump, so you don't need to give too much contrast. You always have a good target to go to with your wire just to the tip of the catheter from above.
Unfortunately. Can I have it? Can you do me a favor? Can you give me a multi-purpose B1? 6 French multi-purpose B1. I'm going to try some other catheter here because I think this is pushing me up rather than down. And unfortunately, we don't have a lot of support from the top, which is a problem for us. So I'm going to use a multi-purpose catheter. I think that may be better for us.
Mehdi, do you also use some other wires in this kind of situation, like CTO wires, maybe from
Yes.
retrograde even?
Yes, we can. I'm a little bit concerned about the retrograde up there because it's so free. Don't move, please, Mr. Fiorucci. So, but we can use it. I think, can I have let me have a Stado or an approach? 25 or a Stado? Can you see if they have one of those 018 Avid wires? That's another approach to come retrograde. Yeah, this is not going to help me, so let me change this here quickly. Can I have the multipurpose B1, please?
Yeah, the other thing working against this is the very sharp angle of the aortic bifurcation, and at each angle,
Right.
and we'll talk about that tomorrow in wires, each angle adds a problem in terms of torque. And so the more of those we have, the more difficult it is to torque, and that really gets amplified sometimes with CTO wires, where we lose some of that penetrance because we just can't move like we want.
So yeah, so that sheet is stuck up there right now. We can't get it through now. We could get a 5 French sheet, but let me try this multi-purpose first, and then if this doesn't work, we may put a 5 French sheet just to be able to get some work done. But these are some of the issues, we tried different techniques, as I mentioned earlier. We tried some of the techniques to try to get that sheet down, but we haven't been successful. So I think we need more support. What's the word? So I'm going in now with a multi-purpose catheter. This is 6 French. I think we may be able to hopefully get this to the knob. Okay. Can I get a 5 by 60 balloon, please? Okay, go ahead. 035. Put it working. Wire came back in. That's okay. Go ahead. Easy. Easy, easy, easy. Yeah, go ahead. Go ahead. Okay, go ahead. Go ahead. It's hard to see this stupid. Okay, 1 second. Go ahead. Okay, stop. Let me get in there.
Yep.
So let's see if this multi-purpose works. One, can you bring a 5 by 90 sheet, please?
Mehdi, what's the sheath in there now? Is it 655?
This is 755. Give me a latest. This is 755 sheet. No.
Is it an Ansel sheet or is it a Balkin?
It's an Ansel sheet, yeah. Okay, I have a good force now. Andy, can you tap this in? Bring
Yeah,
the
that's
wire in and
encouraging.
just tap it. Yeah, tap it in there. Go ahead. Tap it in there. So Andy is going to try to tap it in. Push. 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 Yeah. Okay. Okay, 1 second. Come over here. Hold it in. Okay, push it down. Okay, stop. Come down, push it down. Push it down. Okay, stop. It's hard to see. Okay, good job. So that was the technique, I guess. In this situation, the multi-purpose helped us. So I think we crossed it now. So let's see what we want to do here, for a second. Let me see something. Let me come over here. So what I'm going to do, I'm going to bring this multi-purpose down a little bit. And I'm going to see if I can wire it with this wire here. Andy, come over here. Put it on. Pull the thing back. Navi cross back. Put it back. Navi cross back. Back. Yeah, put it back, Andy. So I'm just going to try this for a second. Can you rotate that one? See if you can rotate it. Rotate it a little bit. Yeah. Okay, that's good. So we try this for a second. If it doesn't work, I'm just going to angioplasty, reverse card kind of a situation.
Yeah, but it seemed that you already connected both lumina, so it's probably.
I thought so too. I thought
Yeah.
so.
So it's probably
But it doesn't
easy.
look.
If
Oh,
you,
here we go. Here we go. We got it. All right. Good job. Okay. Put this wire back, please. Put this wire back. Put it on. Okay, so now we are able to extract. Can you show this area here? Let me pull this out. You have the wire here? Put it on. Okay, the wire is out, so we can take this out. Okay, the wire is out. So we externalize the wire. Now we can rail that. Give me the dilator for the 7 French sheet.
So now he has a tethered wire, and that gives him profound support. He's going to be able to push pretty much anything over that, regardless of how long or how tight. And it negates this loss of vector force at the aortic bifurcation where the natural vectors want to go cephalad.
So what I'm going to do here, Dr. Walker, is that now I'm going to bring the I'm going to take this out, the Navicross. I'm taking the Navicross out now. I don't need the Navicross anymore. So the Navicross is out from the retrograde and the antegrade. We're going to bring this wire a little bit back from this side. Put it up, please. And now what we're going to do is that we're going to put the dilator of the sheath back in there. So the dilator now is going to go back. Can you put this? You're younger than I am. My eyes, I'm getting, near far-sighted, so these guys make fun of me, They're young and... Okay, hold the wire. So put it... So let's get it. Can I get another Kelly clamp?
So
give him
now
a
he
quick
should be able to
Kelly clamp.
hold the wire on both ends, and this ought to track a lot better.
Yeah, so we're going to hold, exactly. So we're going to hold here, and Dr. Goodman here is going to hold on both sides. And I'm going to see if I can push that sheet down. That would be great. Then we can work. There we go. Okay, go ahead. Hold this too. How you doing? Can somebody check on him, see if he's doing okay? Hold, Mom. Hold tight. So this is the advantage of this technique. I cannot tell you how much force I'm putting there right now. It's unbelievable. But, that's the only way you're going to be able to get that sheet down, honestly. So now we have the sheet down and we can go to work. So what we're going to do is that we're going to put a Navicross in an antegrade fashion and then go from the antegrade approach and see what's going on. I think that to answer Thomas's question from the beginning, that why didn't go from the AT, I honestly a little bit uncomfortable doing all this pulling and pushing and all the force that I need to get that sheet down, given the distance from the AT and given the fragility of the AT. So I don't know, that's just me. I mean, I guess, you can do it. But I felt like we really needed a lot of force. We needed an 035 system. We needed a hefty system to be able to get down. And I felt that, the popliteal stick was not that risky.
Mehdi, at the end of this case, you're going to have to remove that contralateral sheath, too. And I'd be really careful with that. I've seen even braided sheaths separate. And, by taking precautions ahead of time, by putting, for instance, a balloon that you can put distal and help to pull it back, you can salvage that situation. Yes. Because I've seen these clearly snap in the past.
Can I have another stiff angle glide wire?
Yeah, you should at least
Absolutely.
introduce the dilator before you pull the sheath back.
Yeah, at a minimum, a dilator.
Yeah.
Maybe even a balloon distal sometimes.
Can I get that 5 by 150 balloon? Let's go. Open it, please, Annie. Mr. Fiorucci, put your leg a little bit straight, my man. You're doing great. You're doing great. Okay, so we are now down to where we were. So now we can... let's go. Take this out. Take that sag out. Yeah, pull it up. Pull it up. Pull it up, yeah. So I'm just holding some pressure here in the meantime in his popliteal area, you know. Can you write that? Yeah. Keep going. Can you look for a... Okay, push it. Look, push it. Yeah, let me see. Yeah, come over here. Put some pressure here. Give me the torque, please.
Mehdi, this is another stiff-angled glide wire.
Yeah, this is another stiff angle. The other one was obviously destroyed. And I think in these cases, after give him an ACT when you get a chance. Move your hand. Move your hand. After a little bit of time of working with the stiff angle glide wire, I think you need, I mean, look at the amount of calcium there. So one of you guys got to go to the other side. So I'm just going to...
So, Mehdi, you mentioned an ACT. There are differing approaches based, it seems to me, mostly based on the specialty of the operator. Do you have any feelings about heparinization or what's the appropriate anticoagulation for these types of cases?
So we are right now with heparin. Can you go back in? Go in, push it in. Can you please bring... Oh, we can't do that. Can you turn this monitor's level so that Goodman can see? Come down. So we are dealing now with another lesion. So again, going back to Thomas's point, if we had come from the AT, maybe we didn't have to deal with this right now in some ways. But you know, these are the challenges we deal with. So I'm just going to force a little bit. Go down, please, push it. But if we didn't bring that sheet down, we couldn't do any of these things. You know, so bringing the sheet down was extremely important, I think, in this situation to be able to do some of this. So come down a little bit. All right, stop right here. Let us reassess the situation. So I think in this at this moment, I'm going to take some angios and see what's going on. Okay. Heavy calcification there, as you can see. So we got another 3-4 centimeter, and then there is another occlusion. So it's obviously a challenging case for us, but that's why we put it on. Come down a little bit. Okay, stop right there. Stop right there. Okay. So little by little, you got to work your way. So I think here the wire seems to be free, maybe, but there is another.
That's a great sign. He's in a collateral right there, and eyes beyond. Always pay attention to that. If you have a total occlusion, if you get into a collateral, that often is a good clue that you're heading in the right direction.
Watch it, examine. So we are here now. So why don't you, Andy, see if that navicross goes down a little bit more, and then we can take a picture and get a sense of what's going on back down here. If you can rotate it, also it will go. Okay, that's perfect. Actually, come a centimeter more. Yeah, see if you can come a centimeter more. Rotate it. Yeah, rotate it and push it down a little bit. Doesn't want to go anymore? Okay, stop. The other issue is that we got to make sure our sheet doesn't kick out. So now the sheet is good. Let's make sure. Yeah. Okay. So we are here. What I'm going to do now, I'm going to remove the wire and take a picture. Is that okay with you, Craig? What do you guys think?
Yeah, I think that's reasonable. Your wire seems nice and free. At least it seemed that way up until that movement. But I think it is free.
Yeah, and we have good blood. It looks like we have a little bit of blood flow here. So let us check here. Yeah, we're getting a decent blood flow.
Very nice.
Yeah. And we have this below the knee disease. So now the question is, what should we do with this? Mr. Fiorucci, can you put your leg up with your toes up in the air? Yeah, there you go. Thank you very much. Can I have that syringe again? So one more picture here, just to give us a sense. Better mag out a little bit. Yeah. So I think, I think maybe what we do is that let us balloon this a little bit here, if you guys agree, so because we are having a hard time getting devices down.
Yep.
I'm thinking of maybe putting a woolly wire down here, ballooning the SFA a little bit, and then deciding how we're going to approach the below the knee and fixing the SFA. Is that okay with you?
It is. The other option would be to put a small wire now that you're across, because you've pushed the nav across, which is a reasonable profile, and any of the 18,000 balloons should cross in the path that you've just made.
V18, quick. Let's try the V18. Let's see if we can get into the peroneal. And then we use 018 balloons. Can you look for me for the 018 5 by 120 balloon and 150? 018 5 and 6 by 120 and 150. Now we can change to I'm going to try a V18, see if I can wire it with a V18. And if I can wire it with a V18, then I can go with the 018 balloons and balloon the whole thing.
Sure.
That may make my life a little bit easier.
I think it will make the SFA life easier anyway. You've pushed the nav across while you had extra support. You've made a channel with the nav across, which is should be bigger than the 18,000 wire-based balloon. So I think this should cross reasonably easily now.
Yeah, and you will need an 18,000 guide wire anyhow if you want to implant a supera, so downsizing of the guide wire makes sense.
Yes. Okay. I just hope this wire goes. We may have a channel there actually at that. Yeah. Maybe you want to put this as a roadmap. Oh, it is there? Okay.
Mehdi, I think this is the easy part compared to what you've done. This is a remarkable case. You've done a great job getting to this point.
Yeah, very nice. I think it's also very important that you re-entered here right into the open artery at the genicular area. Otherwise, if you would have dissected further down, you might have lost this genicular collaterals. What do you think? So,
oh, he moved, so his leg moved. So give me another, let me see. Oh. Now, by the way, I have very little control of the wire here, as you can imagine.
Yeah.
But it's very tight. Oof. I don't want to damage.
Yeah, well,
let me take another picture here. Let me take another picture.
In the image you obtained before, it looked like a CTO here, a short CTO.
Yes, and maybe that may be the case. So we are right at that area too.
At least subtotal.
Yes. Let me have that 5 by 120 balloon. Tell us balloon a little bit. Yeah, we need 018. Let me try this one more time here. The wire is not acting the way I like it to, but, and I don't want to be too aggressive with it because I don't want to dissect it. Okay, it went.
Great.
So,
the other thing that can really be helpful here are the wires with micro braids. Those will really torque when coming around. So obviously, as we look, and we'll have a talk tomorrow on wire technology, but the new micro braids, instead of just having either a nitinol or a stainless steel shaft, there's a micro braid around them, and you can torque them even with extreme tortuosity. Very nice.
It's very tight. The system is very tight. So let us give it some ballooning. Now, obviously, I know Thomas already mentioned supera. So one of the challenges is that we have to really prep this vessel, as you all know. And let us go with a 5 and then decide what we want to do.
So would there be another option to treat this terribly calcified long lesion like atherectomies? Is this an option? Maybe
I'm sorry,
Thomas,
Andre, what did you say?
Maybe would another option be an alternative like atherectomy, or is it too long and too calcified?
Yeah, I think you can use atherectomy. I think the only ones that I would use, honestly, in this situation would be the laser, but it's so calcified. I don't think laser is going to do well. It may. I don't know. I'd be interested as to what other people think. The other option would be CSI, but we are subintimal. And when you are so subintimal, I'm not sure how much it helps you. It may help you. I'd be interested as to what other people think, but
Yeah,
that's my feeling.
I agree with both of your comments. This is really long. It's only one vessel runoff. If you embolize, it's toast. It's a very difficult thing to get out of the problems that occur here. I don't think this is an ideal case for. I think obviously when we start talking a few
Good
centimeters
job. You can get it down.
of calcium, that's one thing for atherectomy. When we're talking 45 centimeters of this kind of dense calcium, that's a different animal.
So I'm going to balloon this now.
Where I see a role for atherectomy is the distal popliteal lesion. So to prevent any plaque shift into the anterior tibial. So to clean this area with focal atherectomy would make sense, the most sense here.
So you're talking about, Tom,
So,
just distal, not the whole SFA.
No, the popliteal,
Yeah.
just the area proximal to the bifurcation into
Yeah.
the trunk and the AT. So that would be something for directional atherectomy, for example.
Yes, that one area would not be a bad thing to do. I agree with that. You know, past the knee joint. Yes.
But if you're going to do
Right
that, you
by
probably should use distal protection here too, don't you think? For this kind of calcium and this 4 down.
Yeah, well, it's a very small reference vessel diameter. I don't believe that he will create too much lumen, and as long as you have no flow around the shaft of the catheter, you cannot embolize at the end, at least not with the turbohawker. But you are sure in general it's something you should consider protection.
Now, you guys are using
give me a-
shockwave, or at least evaluating it in
Could you
Europe
look
for
by
this
40
kind of
below, or
calcium. I think both of you have
by
presented
200,
on it.
180.
Have you found that
If you have
useful
it,
for
no.
this?
Did this burst?
Shockwave, yeah, we have done very few cases. I mean, I saw some impressive cases, some were not so impressive.
So the balloon just burst. Can you show this? Let me have another indefibrillator. The balloon just burst in that area.
That's
We
not
can use that one,
surprising.
yeah.
You know, sometimes in these cases, we'll pre-deal with these, then maybe even sometimes try to go in with Kevlar balloons to dilate. This can be a very tough area to dilate with that much
Yeah.
calcium.
Yeah. But again, talking about
So-
atherectomy, in this very eccentric calcified area here, where the balloon did rupture, this is something which will benefit from directional atherectomy, because you can orientate the cutter exactly towards the calcium, and with this definitely increase the vessel lumen. But nevertheless, this is something which needs to be done in a protected fashion. Yeah. So this pervasation is probably a result of your previous stick. I don't believe that this is related to the
Can
rupture
I
of
have the
the
balloon,
balloon.
please? What's going on? No, I need to see. Yeah. 6, yeah. Give me both. Honey, I tell you to keep both. Don't wait. So I'm going to go down with the 3-0 right now. Hit that TP trunk, and then in the way out, we're going to go with the 6-0 and try to see if we can open that up a little bit. You know, one of the issues with directional atherectomy here is that trying to get that 7 French device down all the way to that area does concern me. And also the fact that the patient has 1 vessel runoff and significant ulcerations.
Well, he has 2
I don't know,
vessel
I think
runoff.
that-
He has the AT and the peroneal. So this is
Yeah, the AT occludes, yeah, I'll show you. Go ahead. So we're going to go with a 3-0 balloon. You should go, Andy. So come.
But to be honest, I would not treat the distal popliteal at the moment. I would finish the SFA and proximal popliteal because even if it's unlikely, but if you would embolize, the subtotal occlusion would protect the outflow at the moment. So.
Yeah, you know, I know that's potentially could be a theoretical advantage. It's just that we rarely go and suction these out. You know, even when we do it that way, it's rare that, you know, we go with angiojet, or I'm not sure some of the manual aspiration catheters have the power to take out calcium and chunks of plaque that we get from these procedures from embolization standpoint. So short of going in there and doing angiojet and all kinds of, you know, doing more high level, you know, thrombectomy or whatever it is to suck those debris out, because it's unlikely that's clot. It's most likely going to be plaque and debris, and it may be some clot too, but it's going to be very fibrotic. So I don't know. What do the other people think on the panel?
I'm not seeing any consensus right now. People are just thinking. I noticed you were oscillating you still are oscillating your inflation as you go up. I don't know what kind of pressures you've gone up to this point.
Yeah.
But
this is 14 actually.
Okay.
This is 14, and you mentioned that, so in memory of Dr. Whitlow, who, as you may know, Dr. Walker just passed away 2 weeks ago.
Yes.
We actually call this maneuver Whitlow wiggle. At least that's the term I've given it, because that's what he taught me to do when we used to do those tough coronary lesions. So basically, you know, you go to your maximum pressure. In this case, I'm at 14, and then I just go down to 10 and 14 and just do this maneuver multiple times. And I remember working with him, you know, 9 out of 10 used to work eventually. So that's something I learned from Dr. Whitlow, and I continue to do.
Otherwise, if this balloon wouldn't open, maybe some other alternative balloons like scoring balloon, Vascular, or high pressure balloons. What do you think?
Yes, and as Andreas said, so we can use angioscope, we can use chocolate. Those are two options we have here that we can use. Obviously, there's always the opportunity to do atherectomy. Okay, so now I'm going to go with that 6 balloon that Thomas wanted. And, you know, the 5 burst, but I'm going to try the 6 and see if we can get some flow there, so we can then make a decision as to what we want to do. Okay, pull the wire. Sorry.
Yeah, I think
Okay,
Supera has really opened up options in treating this kind of case that in the past was tough. Often we would put standard nitinol stents here and they would simply get crushed. And that doesn't seem to happen if we can aggressively predilate. It's going to be the
Let me know if he's back.
big issue here is going to be, can he fully inflate this? And I think he's going to pay a lot of attention to pain to see if he's causing pain as he goes up, because that's often a precursor to knowing if someone's going to go on to rupture. But even in this kind of dense calcium, it's been our experience that Supera routinely can open these with appropriate pre-dill. Haven't you guys seen the same phenomenon? Is this your go-to for this?
Can you bring me a 6 by
So
120 Supera?
for me, I'm looking, seeing this kind of artery. I think this is the only solution you have, is Supera, and to be able, I mean, atherectomy maybe to prepare for the implantation for a Supera at some areas as this very calcified plaque, but at the end, I think you cannot come along with other devices here, except for Supera.
Yeah, I've been impressed Supera even gives good patency in this sort of situation, which in the past was pretty hopeless for us anyway. So, Manny, did your balloon fully inflate there? The picture's off of the balloon? It
yes,
did. Good.
It actually did, and this is a 6.0, Dr. Walker. So
great.
The balloon inflated nicely there and is inflating nicely here.
Nice.
So I'm going to go down one more time and show you that part.
Sure. So one of the things he's doing here is it's very important if you consider using Supera. I would say that 9/10 of the battle with Supera is vessel prep. If you don't prep the vessel well, then the stent comes out elongated, you don't have proper architecture, you lose the mechanical advantages that you sought out in the beginning.
Yeah.
And so a good prep is everything,
See
in
if
my
you can-
opinion.
Okay.
And when I've seen people fail with that device, it's usually because of poor prep.
Go down. So here we're coming down. It's going easy, as you can see. So go down a little bit more. Right there. So I'm going to hit this part again with a 6-0. I have concerns, as mentioned by Thomas and Andrea and you and others, about the Supera, and sometimes if the vessel is not very well prepped, it can catch, and as you said, unravels the stent. And that area that you can see is a chunk of calcium pushing the artery. We were subintimal. That obviously worries me. That's the area that the balloon ruptured too. But it looks pretty good, except that one area. What do you think, guys?
Can you take an oblique view of that? Because sometimes if you take an oblique
Yes.
view, you realize it's just simply being displaced and it's yet fully expanded. And so sometimes, even when it doesn't look like it's fully expanded with an oblique view, it appears to be that. I think that's not fully expanded, unfortunately.
So what about taking maybe shorter balloons to adjust to that areas where this long one doesn't open up to have
Can I
more
have
focal pressure?
Can I have a 6 by 60, reef, yeah. So I'm going to get a non-compliant balloon, although it's looking better, Andre. I don't know if you can see, it looks a little bit better, but I'm going to take a shorter balloon and a non-compliant balloon, or semi-non-compliant, a reef balloon, and try to see if I can get it. But I think the rest of the vessel looks pretty good. You agree?
Yes. I think the other option, of course, are focal force balloons, and the other would be ultra non-compliant with high pressure, something like a Kevlar-based balloon. Those will typically open these
Yes.
up.
You mean like a Dorado?
Yes.
Yes. Okay, I'm going to take a couple pictures here, just so we can at least see, and then we're going to get that other balloon, the short non-compliant balloon or semi-compliant balloon. Okay. So let us take a couple pictures. So we have some tear at the proximal parts that we expected. And then the middle of the SFA actually doesn't look that bad. And then we have this area, obviously. Can I get that 6 by, you want to put 6 or 6.5 for the Supine? What if we put on the other side? It actually doesn't look that bad, to be honest. What do you think,
Yeah, I think it looks
Dr.
very.
Walker?
I think it looks very good. Still, my bias in this kind of a case would be to stent this entire area.
Yes.
I'm not a big fan of, in general, of full metal jacket, but I think this is an area where that would be my approach. How about the rest of the panel? How would you treat this?
Well, basically, I would do the same as Andre mentioned, to use a short 6 millimeter balloon to further prepare this focal highly calcified
Can I
area,
get 6 by?
because otherwise
Can I
the
get 6?
superior will not open. I would say
Yeah.
the remaining SFA looks pretty good, so except the origin. I would reserve the superior only for the distal SFA, including the calcified chunk, going down to the P2 level and the SFA. The remaining SFA I would simply treat with drug-coated balloons, and for the origin you might need a short stent in addition.
Tom, have
Yeah,
your
I was
results,
thinking actually.
have your results with drug-eluting balloons been good in this kind of calcium?
Well, this area will not respond to drug-coated balloon.
No,
It's a mechanical problem, but everything proximal to that will
Right.
look very good and on
Right.
the long
Okay.
run. So
Yeah.
the outcome is pretty convincing.
What?
Also, the data we gained from the Impact Global registry, we enrolled a lot of this kind of patients into this registry, where we performed provisional
What's number?
stenting in areas like this, and the remaining vessel remained without stent. So I would combine
And the balloon that I'm using, Annie?
focal
That's the
stenting and DB here.
Maybe they could try with the shoulder.
So Mehdi, what kind of
So
pressure?
so let me ask you a question. So this is what the pop looks like. Let me stop this and let us discuss this because I'd be interested. So this is what the pop looks like right now. So do you feel that we need to put a stent there? Do you feel like we can just do DCB? I mean,
No.
because I don't think there's much dissection in the pop, to be honest with you. I think the pop has a little bit of calcium. I think most of the dissection is actually a little bit higher at the Hunter's canal.
Yeah, but I would start with the supera at the knee joint and go up to the level of the proximal part of this balloon with the supera stent. And the remaining
give me
vessel
one-
can be treated with a DB only.
Yeah. Okay, give me that supera. I'm going to go with the 120 supera then. Hold on one second. Let me see. Yeah, okay.
Or
Tom, would you
150.
treat the origin any different because it was a total occlusion and it had prior score and they've re-access may be difficult?
Well,
Would you-
my concern here is this is a
Can you look for a
situation
6
after
by 1
surgical
zipper
reconstruction, and it could be an area of patchplasty even, so that this is a very big origin or was a bigger diameter of the origin, and it could be that this is all
Can I have the
thrombus
6 by
what
Dorado?
causes the
Dorado?
residual stenosis. So if you would use a stent, you should use a very large stent, at least 8 or 9 millimeters in dimension, to really cover the true dimension of the origin of the SFA. What would be very helpful here is to have an ultrasound at least to measure the dimension and to calculate the dimension of the stent here.
Any other
Okay.
panels? What else would you guys do? Andre, what would
Or
be
do
your
IVUS
approach?
or whatever. Yeah.
Well, I mean, definitely, as Thomas said, first of all, distal popliteal, distal SFA has to be stented, and then I would postpone the decision whether to continue with stenting to after that step. Then you can compare how the proximal part looks like in comparison to the distal stent, whether you have a lot of recoil proximal or not. Not sure whether, to me it looked like quite some recoil, and I'm afraid that the stent has to be longer up to the confirmer, but yeah, I would decide later on.
So, Craig, we are going to go with the Supera 6 by 120 right now.
Okay.
I went as high as I could. I think that area is going to give me a hard time with the Supera. I know it already.
Sure.
So I'm going to declare it. I'm going to declare it before we get to it, but let's see what happens. I think we're going to have a little bit of a challenge, but I did as much preparation as I could.
It will
Yeah.
extend,
Again,
so it
these
will be larger.
devices have changed the way that they're labeled. So a 6.0 Supera is what used to be labeled as a 5.5. The inner lumen of a 6.0 is 5.5. The outer lumen is roughly 0.78 millimeters bigger, so a little bit bigger than 6, probably approaching 6.2. The reason that's important is you wish to prepare for the outer diameter of this to achieve the inner lumen that you're trying to achieve.
Don't want it. The 15 is hard to control, Yeah, I am going to try the, let's go with the, let's see here. Let me take a picture here. I may have to put 2 Superas, to be honest with you. And I tell you what, my own experience has been that, with this kind of a situation where the lesion doesn't give and is heavily calcified, using the longer Supera is a little bit more challenging. Now, it just could be my experience. Maybe I don't use it as much.
He needs
But what
some-
I'm going to do is I'm going to push this Supera down a little bit.
Yeah,
Do
you-
this one and then put another one.
Exactly.
So I don't know what.
You need to go down to the joint level at least, and then
Yes.
yeah.
Go down. Give me another Supera, please.
So
You
this
go down
is
there.
made of 6 line pairs of wires that are interwoven. And in order to grow axially, it foreshortens longitudinally. Ideally, if you want this to have appropriate characteristics and you look at the patency, you want it to come out roughly length to length the same as the nominal length. So in a 15 centimeter stent, you'd want it to be within 20% of 15 centimeters long. If it's longer than that, patency rate falls. If it's shorter than that, it falls a little bit, but it's not so bad. But elongation is a big problem, and that's related to how well you prep the vessel. Sometimes you can even stack it, and over time, if the two ends are roughly at nominal lengths, it will help to reorganize itself. But if it comes out really long initially, it's very difficult to straighten that up in the future.
No, don't put it. Okay. No, that's good. So I'm going to try to deploy this here if it's okay with you guys. Can you show my hand? Can they see my hand? So the issue is that you want to hold the handle in one hand and you want to have your other hand as close to the sheet as possible, trying to control this as best as you can. Okay? Can you grab that from here?
Another thing I think is important, Mehdi, is to magnify and to center this, especially as you begin. I would magnify so that you can see the geometry.
Yes. Okay?
Yes, much better.
I'm going to go in a little bit more.
So again, for the audience who's not seen this, there's a little bullet at the tip. He's pushing it forward. And as he does and he shoves a ratchet forward, you can see the stent is starting to exit. It's coming out here actually in the popliteal segment below the knee. And he's ratcheting it back and he's holding the sheath, the restraining sheath. And it's a reciprocating ratchet that he is using to deploy this. And by pushing the restraining sheath forward, one can actually pack this stent.
A lot of resistance, as we thought.
Sure.
Hold it here. Hold it. Don't hold it there because you hold my stent. So I'm taking my time. There is no reason to rush here. You know, you got to take your time with this stent and try to do a good job.
Yeah. So practical tips for an audience when you do this. If you've not put these in before, put a dummy stent in a sterile bag on the side, and that way you see a nominal length and you can see the architecture, and then you try to match that architecture. Very important. Also, if you have dummy stents of the same length, put them out and try to match the length. If part of the stent comes out compressed and part is elongated, typically it resets itself. But as I said, if the whole thing comes out elongated, it's problematic.
So we have so it's very tight, as you said, Craig. You know, so Flora here, just pan down, make sure the wire is okay. The other thing is that you got to be very careful with this because it pulls the wire. As you're doing this, it pulls the wire. So you really got to make sure your wire is down. And you got to check that once in a while. He always pulls the wire down. Can I have a wet gauze, please?
It's a great point. You want it really, especially with the 18,000 swar. If you do this over 14, there's a little tolerance, and so the reciprocating ratchet doesn't pull it out. But with an 18,000, there's much less tolerance, and you often will pull the wire back distally.
So elongated a little bit there. I'm having obviously a little bit of a challenge here, but
yeah, it's a tough case. I mean, this has been a tough case from the get-go, and there's not a great option in this kind of calcium. And as you could see, even from the multiple surgical procedures, even that was fraught with problems. I'm having a little bit difficulty seeing it. It may just be the angle of my monitor right now.
is the calcium,
No space.
Craig?
Okay.
So pan up a little bit.
But unlike other stents, you must really view this stent as you deploy it. And that's, I think, the other thing that became very obvious.
If you haven't started to use these kind of stents, don't start with such a case, because this is really difficult here. You see, it's not so easy.
Absolutely.
And if you choose a very simple artery actually to take the stent into, it's a completely different story and very easy to deploy. However, here it's clearly difficult.
Again, the things to keep in mind here, as Andres said, is that you don't want the stent to coil. You don't want the wire to come back. You want to take your time. There's no rush to do it quickly. So you got to bring your mentality out of the nitinol stents out. So you see, like right there, you see that? So that was a little bit of I caused that. The other issue is that sometimes if he elongates, you can then stack it right after.
Right.
So try to, you know, Andre, can you comment on that, or Craig or somebody?
Yeah, you see, there are areas where the stent is very densely packed, as now, where the tip is moving upwards. So there's, you can call it some kind of depot of wires. And then he may approach an area where it's then again a little bit more difficult to pack. And because of that depots of more densely areas, wires, over time you see that the stent evens out more, and you see that the appearance gets more regular because you have some depots of wires which then can move upwards to that areas where it's not so much packed.
Yeah, the other thing we found useful is if you have some areas that are compressed like this, in the post-dilation protocol, go with a short, not a long balloon, and that allows the stent to reformat itself. If you go with a really long balloon, it tends to pin it, and it does not allow the stent any movement. So right now, Mehdi, it's saying we have no time left. I'm not sure because we'd
Yes,
started a little
that's
bit
okay.
late.
Yeah, I think we have a few minutes. So we deployed that stent. And I'm going to remove it now.
Go ahead. So actually, the reason for
So what-
using this stent is it has so much more resistance to elastic recoil, about 4.5 times the compression resistance of standard nitinol tubular stents. And as you could see in this case, where even a balloon at high pressure was having trouble opening, the stent does have a lumen through a good bit of it. But if you're going to post-dilate this, I would strongly urge you to go with a really short balloon.
So let me show you a picture of this for now, at least, just in case, so you can see what we did here so far. 1 second.
Yeah, at the end we are already a little bit over time. But what you need to do before you extend with the second stent proximal, you need to post-dilate.
Yeah. Yes, absolutely. That's a very good point, Thomas. So what we're going to do here is that we're going to post-dilate this. I'm going to put another supera, and then I'm going to assess the rest of the SFA, see what it looks like. If we can get away with DCB, we will do DCB of the SFA. And then for the ostium, I'm most likely going to use a Zilver PTX. I promise I'll show the case tomorrow morning so you guys can see the rest of the case. I think we have to start the next session. Thank you very much.
Phenomenal case, and thank you to this great panel for all the great suggestions here. Thank you much.